Good afternoon, respected dignitaries on the dais and everyone. This is
यार
Dr.
जस्ट अ मिनट यार बैठ दो सांस तो ले लेने दो डॉक्टर साहब को तुझे बोला ही नहीं तो शुरू हो गया एनीवे डॉक्टर अक्षय मोहन ना
Yes, sir.
ओके यू स्टार्ट विद योर प्रेजेंटेशन
I'm going to present
प्लीज
about
नोट द टाइम 4 minutes
I'm going to present about orthoptic importance of refractive correction in phakic plane in unilateral high refractive errors, a case series. As we all know, anisometropia causes disparity in focus and difference in clarity of size of image on retina, which results in the impairment of fusion, often leading to strabismus. This deviation remains largely unchanged with use of glasses, but with refractive correction by other means like phakic IOLs, clear lens exchange with multifocal IOLs, piggyback IOLs, etc., this significantly improves the quality of vision, enhances binocular function, and has a positive impact on ocular deviations. Aim is to study the effect of refractive correction in phakic plane on orthoptic parameters and stereopsis in unilateral anisometropic high refractive errors. We report a case series of 4 patients proving the orthoptic relevance of surgical refractive correction in unilateral high refractive errors in young adults. The patients underwent surgery after informed consent. First case was a 21-year-old male having 6/6 vision in the right eye, and in left eye his vision improved to 636 with +8 diopter sphere. Patient had left exotropia of 35 prism diopters and left eye suppression. Diagnosis was severe aniso-hypermetropic amblyopia in left eye with sensory left exotropia. Patient underwent clear lens extraction with multifocal IOL. The AC depth was 2.4 mm, and patient wanted to be spectacle free, so this was the only choice. In post-op period, the patient's vision improved to 612 and control of exotropia also improved. The stereopsis on Rendot improved to 160 seconds of arc. This is the pre-operative and post-operative photograph of the patient. Post-operative photograph showing control of exotropia post-surgery. Second case was 20-year-old male medical student facing difficulty in enjoying binocular vision while looking through a microscope. Patient has undergone a repair of corneal penetrating injury with lens aspiration and in the back IOL implantation in left eye 8 years back. Patient's visual acuity in right eye was 6/6 and in left eye it improved to 612 with -8 diopter sphere. Patient had glaucoma adherence with pseudophakia in the left eye and also left eye suppression. So diagnosis was glaucoma adherence with pseudophakia with anisomyopia in left eye. Patient underwent piggyback IOL implantation in the left eye. The vision improved to 612 and stereopsis on Rendot was documented to 100 seconds of arc post-operatively. This is the pre-operative and post-operative slit-lamp photograph of the patient. A is the pre-operative photograph and B and C is the post-operative photograph after piggyback IOL implantation. Third case was a 21-year-old female having -4.5 diopter sphere in right eye and in left eye -20 diopter sphere through which vision improved to 660 and there was left exotropia of 30 prism diopters and left eye suppression. Diagnosis was myopia both eyes with sensory left exotropia. Patient underwent implantable colamer lens implantation both eyes. The power was in right eye was -6.5 and left eye was -23 diopter sphere. In post-operative, the vision in right eye improved to 6/6 and in left eye improved to 624 with -0.75 diopter sphere. The patient was orthophoric for both near and distance and stereopsis on Rendot improved to 160 seconds of arc. This is the pre-operative and post-operative photograph of the patient showing control of exotropia. Case 4 was a 23-year-old female having 6/6 vision in the right eye and -15 diopter sphere in the left eye through which vision improved to 624 and there was 35 prism diopters of left exotropia and left eye suppression. Diagnosis was high myopia with amblyopia in left eye with sensory left exotropia. Patient underwent implantable colamer lens implantation in the left eye. Power was -17.5 diopter sphere. In post-operative, the vision improved to 618 and control of exotropia improved. Stereopsis documented was 160 seconds of arc. This is the pre-operative and post-operative table, which we have already discussed one by one with the patient. The post-operative results at 12 weeks post-op showed binocular single vision and improvement of stereopsis on Rendot in all 4 patients. The refractive correction closer to the nodal point improves visual acuity. A clearer and lesser NIC iconic image would stimulate and enhance the binocularity. For high refractive errors Glasses create significant peripheral distortion. Surgical correction of the refractive error provides the patient with a larger distortion-free peripheral field and a stronger stimulus for fusion. So greater accommodative effort would help in controlling the exotropia. Greater pseudo-accommodative effort with multifocal IOS in the first case and enhanced effort by the phakic IOL in the third and fourth case will play a role. So from this, we conclude that these cases demonstrate orthoptic relevance of surgical refractive correction in unilateral high refractive errors in young adults as an essential part of the initial management of strabismus. Thank you.
Can you show me case number 2 once again?
Yes.
So there was suppression before, right?
Yes, ma'am.
And you say that after putting the lens, the suppression has gone and stereopsis has improved just by putting a piggyback IOL.
Piggyback IOL.
How is it possible? How is it possible? Can you explain?
Ma'am, till 7 years of age, patient may have enjoyed binocularity, and after that, when he got injury, so after that, with -8, he became 612. So the image size and aconia must have played a role so that he is not able to enjoy binocularity when we corrected at the nodal point through piggyback IOL, so stereopsis improved.
Now come to the third case. Here you are saying there was an exotropia of 30 prism diameters,
Yes,
right?
ma'am.
And there was an anisometropia also of -20.
Yes, ma'am.
How do you explain this?
Ma'am, we implant, ma'am,
You are
ICL
basically from which institute? Can I know
ma'am,
that?
KGMC,
Hmm?
King George Medical College.
Where?
The research was done at KGMC
Okay. Hmm.
under guidance of Professor Siddharth Agarwal, sir. ICL was implanted in both eyes, ma'am, and the stereopsis and correction also improved. This is the post-operative photograph of the patient. So
Just
the
come to the
control
previous
improves
slide.
with when we correct at the nodal point.
Please go to
in
the
I-
previous slide.
Yes, ma'am.
Yeah. Now explain. You're coming to 160 seconds, right?
Yes, ma'am. 1 6 seconds
So
of arc.
how much XT was left?
How much?
XT was left.
Ma'am, control was much better. Only 10 PD of XT was on cover and uncovered.
So that is also, you have written ortho for distance in here. You
Yes,
have not
ma'am.
mentioned the XT, what is left. That is supposed to be mentioned in
Ma'am,
this.
10 PD, which is in general practice also we see.
10 PD में फोविया में कहाँ पे तुम्हारा आएगा नोडल पॉइंट से कहाँ इमेज बनेगी ये बताओ मुझे.
I didn't get that.
Like if you are getting it fovea, okay, then stereopsis will improve much better, okay. So now coming, where is your image? You are getting 160 seconds of arc
Yes, ma'am.
and it is 10 PD. Where the image will form?
Ma'am, fovea.
फोविया में कैसे बनेगी? 10 PD है तो कैसे बता भैया फोविया में कैसे बनेगी?
Ma'am, the patient was orthophoric for distance and near. Only
Post operative you are
angle
saying.
kappa was there when we saw post operative.
Now you are changing your statement.
Basically, what is the basic rule in relation to the suppression amblyopia? Right? You are describing the children, not children,
Adults, 20
more
years.
than
20, 21 years.
20, 21, 22, and saying that there was amblyopia, and you are also saying that up to the 12 years of age, children were enjoying with the binocular vision.
No, only the second case must have been injured since he got injury at 8 years of
But how
age.
do you know that he was having the binocular vision? When the child has presented to you at the age of 20 years of the trauma or whatever it may be.
Yes, sir.
So how do you know the things of the 8 years back?
Yeah.
We can only assume that, sir, in that case.
What is the sensitive period? Do you know? I think you might be aware of the
Yes, sir.
sensitive
Yes,
period
yes.
in relation to the
Yes, yes.
amblyopia
Yes,
as well
sir.
as the suppression,
Yes, sir.
right? And suppression is also of the 4 types.
Yes, sir.
You have not described once you are describing the research activities.
Yes,
you
sir.
should also say that this type of suppression is there.
Yes, sir.
And how
That
is
I
it?
noticed,
How
yes.
does it respond to the refractive correction
Yes, yes.
with the child, right? Anyway,
Sir,
any other question?
one more question. Sir, case 3, he's telling 21 years of female with XT with so much of anisometropia. So how can you eliminate suppression? It'll go into intractable diplopia, yaar. It's minus 20 and 30 PD.
Yes, ma'am.
So the patient will have diplopia if suppression goes off. Patient cannot have, like, how can you explain it? I'm not getting it, how it is done.
No, no, he must be concentrated only the orthoptic improvement. No?
Yes, sir, only orthotic improvement.
You must say that the squint has been corrected or not corrected, macrovision will be there or not there. So these are 2-3 points which has
He's
to be.
saying stereopsis 160 seconds.
I'm explaining. Is not right. So probably these things must be discussed with your guides and all that. Siddharth and Vinita. Vinita probably
Yeah,
left. I think.
Vinita Singh ma'am has left.
Quite back.
Yes, sir, yes.
Quite. So only Siddharth might be there.
Yes, sir.
Anyway,
Okay.
good presentation.
Thank you.
Thank you, sir. Thank you.
Thank you. So the second presenter is Dr. Anupam Singh. इसको बंद कर दो मैडम. नहीं फिर भी बंद कर दो. 15 मिनट.
Very good afternoon, one and all. I will be talking about the bilateral idiopathic optic neuritis and acute acquired common isotropias. And I am going to report 3 unusual cases which are not reported till date in literature. As we all know, acute acquired common isotropia is characterized by sudden onset isotropia, which is usually more than 15% after, and usually age of onset is more than 1 year. It might be earlier as well. And deviation is, the difference of deviation between all cases is less than 6% after, and etiology may be functional or neurological. And hereby I am going to report 3 unusual rare cases of acute acquired common dystropia in 3 boys who reported with, who came and became, after MRI neuroimaging, the final diagnosis was bilateral idiopathic optic neuritis as an associated neurological finding. A 9-year-old male has a history of onset of acute onset of inward deviation with blurring and mild diminution of vision in both eyes for 1 month. There was no significant history related to excessive near work, trauma, or mobile phone use. And family history and birth history was insignificant. Best corrected visual acuity was 6/9 and 6/6 with minimal refractive correction, and which cycloplegic refraction was done. And tear segment was within normal limit. Color vision was deranged, and contrast sensitivity was 1.65 on Pelly-Rapson chart. Pupil was ill-sustained, although normal in size. Extraocular movements were full and free. And on Husbach, there was 30 degree of isotropia. And prism bar test revealed 65 PD of isotropia. AC by ratio by gradient method was 3:1. Fundus was absolutely normal. And in our institute, we routinely do a neuroimaging in all acquired isotropias. And on MRI brain orbit with optic nerve cuts revealed significant toxicity of bilateral optic nerves with enhancement on contrast, which was suggestive of optic neuritis. And patient was referred to a pediatric neurologist, where CFS analysis and immunological workup was done, and everything was negative, which led to final diagnosis of bilateral idiopathic optic neuritis. Methylpred pulse therapy was given for 5 days, followed by oral steroid. And after resolution of this optic neuritis and taking clearance by pediatric neurologist, the squint surgery under general anesthesia was done. And the final alignment was patient was absolutely orthophoric, and he's maintaining alignment till last 1 year. The second case, again, is boy, 8-year-old, having similar history. All parameters were almost similar. The prism bar cover test was 50 PD, AC by ratio was 4:1. MRI revealed bilateral optic neuritis. Again, same, VEP was significantly deranged. CSF and immunological investigations were normal. Patient underwent methylpred therapy. After 6 months of resolution, squint surgery was done. Patient is orthophoric and maintaining the alignment. And there is no recent onset of neurologic optic neuritis episode. Then again, the third case is 6-year-old, youngest one, again male. Similar history, and prism bar cover test revealed 60 PD of acquired isotropia. AC by ratio is 3:1. MRI revealed bilateral toxicity and enhancement on contrast images. And fundus finding was, all 3 cases were absolutely fine. And then again, pulse therapy was given, and after resolution, the squint surgery under general anesthesia was done, and patient is maintaining the alignment. So, as of now, all reported cases of acute acquired comitant isotropias Neurological associations are astrocytoma, medulloblastoma, tumors of brainstem, cerebellum, cardiac malformation, cerebral astrocytoma, etc. Our experience is different from others as we have bilateral idiopathic optic neuritis, which is not reported till now. And the unusual case is all were boys between age 6 to 9 years, and a similar history was there. There was no history of excessive work or mobile phone use. And all of them were diagnosed on neuroimaging only. They complained only of blurring of vision. The diminution of vision was not very significant. And coincidentally, the patient was diagnosed to be having bilateral idiopathic optic neuritis. To conclude, most cases of acute acquired comedentopia result from disruption of binocular function on vision, psychological stress, hypermetropia, or myopia. And to best of our knowledge, this is first report. And we recommend neuroimaging in all cases of acute acquired comitant isotropias, and multidisciplinary approach is recommended involving neurologists, neurosurgeons, and ophthalmologists to manage these cases. Thank you. Yes, ma'am. This is the previous orthophotic recent, and after within one month back, patient was ortho, and the same age, similar age, esotropia was there. Yes, inferior oblique overaction was there.
So what are the 3 points for inferior oblique? To do surgery, like 3 methods of doing it. And you have done 12. So what are 8, 10, 12?
So I have done by modified Elliott-Nanking method. So She's method is there, and then Fink method is there. Then Elliott-Nanking method, and recently Apton-Call method has also been described. So I have taken from IR, that is Elliott.
IO variation was accidentally related with that?
Sir, this patient, coincidentally, IO overaction was there when, and it was significant. 9 gauge photograph mein itna pata nahi chal raha, but it was significant. FDT was strongly positive. And the thing is,
We are discussing the issue.
FDT was positive.
FDT
for what?
Inferior oblique.
What for FDT you have done? Is it a restrictive strabismus case?
No, ma'am, long acting overaction can lead to, it was not strongly positive, but it was positive. And after doing 12,
Okay, leave it, Dr. Anupam.
Yes, sir.
What was the total duration in which you have found these much cases?
Sir, total duration of what?
ये जो 12 केस तुम्हें मिले हैं,
12 नहीं सर, 3 मिले हैं.
3 मिले हैं,
हाँ.
तो कितने ड्यूरेशन में मिले?
सर, ओवर लास्ट 3 years में ये मिले हैं.
Different times you have operated.
Yes,
What's the
sir.
indication of surgery in these cases?
Sir, patient,
Sometime with the steroid and all that? Or
sir, we wait, नहीं sir, acute acquired comitant dystropia, we wait for 6 months at least, as these patients have tendency, and all of them were advised alternate patching and
6
refractive.
months.
Yes, sir. Alternate patching was advised. The patient did not take.
Medical treatment?
So in between, MRI revealed these things, not bilateral.
Not the treatment. Have you done any from the medical point of view? Before doing the surgery, have you tried something?
Sir, refractive, from ophthalmology point of view, sir, we advise refractive correction and alternate patching only. And
Spasm of the muscle, na? Basically. Anyway. Yeah. Any question?
Like how do you grade RAPD? You have mentioned L-sustain, all of them.
yeah, ill-sustained, RAPD in early stage, RAPD was not there, pupillary reaction was ill-sustained. It is a form of early RAPD. When the ill-sustained reaction is when we suggest them when we put light, people constrict, but constriction is not maintained. Then RAPD grade 1 is when we move to light from normal to abnormal eye. But RAPD could not be present because, ma'am, the condition is, we cannot comment because condition is bilateral. RAPD may we are comparing with the other eye. And that grade 1 RAPD is when we move the light, pupil constricts but dilates immediately. Grade 2 may pupil constriction is delayed. Grade 3 may pupil does not constrict on putting the light, it dilates. And grade 4 is pupil remains dilated all time. Yes, sir. सर नहीं है रिलेटेड, नहीं है, अभी एक्सप्लोर किया है एंड स्टिल आई एम सर्चिंग फॉर लिटरेचर. अभी तक कोई पेशेंट ऐसा रिपोर्टेड नहीं. थैंक यू सर.
Good afternoon, everyone. So this is a case on effect of inferior transposition of horizontal recti on unilateral dissociated vertical deviation. Brief about DVD. It is described as spontaneous elevation, extorsion, and abduction of non-fixing eye. Associated findings may include latent nystagmus, primary oblique overaction, and anomalous head posture. DVD is usually bilateral and asymmetrical. Rarely it is unilateral. Sensory horizontal deviation may have coexisting unilateral DVD, posing surgical challenges. Sensory deviation involves simultaneous surgery on both horizontal recti in same eye, and spontaneous vertical recti surgery may cause anterior segment ischemia and is not recommended. For unilateral DVD, cyclovertical muscle surgery may induce vertical tropia with induced torsion and pattern strabismus, and the transposition of horizontal recti has been used to treat LR palsy, monoocular elevation deficit, monoocular depression deficit, third nerve palsy with satisfactory results. There are anecdotal reports describing inferior transposition of horizontal recti on unilateral DVD, and we report outcome of 3/4 muscle width inferior transposition of horizontal recti resection in sensory exotropia with coexisting DVD. So this is a case of a 21-year-old male with outward deviation of left eye and poor vision since early childhood. No treatment taken in the form of spectacle and surgery. There is also tall stature and feature suggestive of Marfan syndrome. Best corrected visual acuity 6/6 in right eye with +1 diopter sphere, 3/60 with +7 diopter sphere and +1 diopter cylinder in left eye with anisometropic amblyopia with sensory exotropia and unilateral tropic DVD of 12 PD. There is unilateral ectopia lentis in left eye. There is no latent nystagmus, no abnormal head posture. This is the pre-op 9-gaze picture showing left eye sensory exotropia of 40 PD and left eye tropic comitant DVD of 15 PD. On right side, there is a preoperative fundus photo showing left eye extorsion, grade 2. Surgical procedure done. Force reduction test was done on operating table and found negative for LR and SR. 10 millimeters LR recession and 6 mm MR resection with 3/4 muscle width inferior transposition of both horizontal recti was done. This is a result at 6-week post-op. There was minimal residual horizontal deviation and residual DVD after the surgery. There was no change in torsion, no induced torsion, no pattern strabismus was induced, no induced hypotropia in primary position. This is a discussion. DVD is an enigmatic entity posing diagnostic and surgical challenges. Surgical alternatives with unilateral DVD with sensory exotropia is limited as both horizontal recti are invariably operated for horizontal deviation. Inferior transposition in same setting is simple to perform and does not take additional time and can treat up to 10 to 15 PD of DVD. Hypertropia in primary position is not induced and abnormal torsion is also not engendered. There are anecdotal reports on unilateral DVD treated by inferior transposition of horizontal recti. However, there is positive literature on sensory exotropia with coexisting DVD. Long-term follow-up studies with the larger sample size and longer follow-up is required to evaluate safety and efficacy of this procedure. And unilateral cyclovertical muscle surgery may induce vertical deviation in primary position. Concluding my case, this in unilateral DVD with poor vision, with coexisting sensory exotropia, horizontal muscle surgery for exotropia with 3/4 muscle width, inferior transposition of horizontal recti is an effective and safe procedure for correcting unilateral DVD. It may treat unilateral DVD up to 15 PD and sensory exotropia up to 60 PD. There is no pattern, no abnormal torsion is induced after the surgery. Short-term results are stable, and it may not be as effective for incomitant DVDs, and long-term follow-up is needed in such cases. Thank you. Ma'am, 10 mm LR resection with 6 mm MR resection with 3/4 muscle width inferior transposition of both horizontal recti.
Can you show me the slide? It is not mentioned. Yeah, it's mentioned. 10 mm LR transposition कर रही है सर वो.
Sir, LR transposition.
Transpose. तो भाई वो 6 mm कहाँ transpose किया तुमने? ऊपर ही नीचे? Where you have you transpose?
Ma'am, inferior actually.
Inferior.
I do not have.
So what are you going to get there? 6 millimeter down at the 10 mm position. What you are going to get? What anatomical structure you will get over there?
When what is the exact position where you have kept the inferior oblique to transpose the muscle? कहाँ पे किया है?
Sir,
She has transposed lateral rectus 10 millimeter at where we get. You have to tell. I'm not going to tell.
Let her speak.
You have to tell.
She wants to know, even me also want to know that where exact transposition site of the
sir,
inferior oblique. Where you are working right now?
sir, ESIC, Faridabad.
Yes, not GNSC. Because PK was GNSC with me. So I don't know ESI. So where exactly you should know na you? That was your thesis.
No, sir, actually, I have assisted on this case with sir.
So you should know na. You are presenting the things.
Sir, actual measurement, actually, I
Okay,
have not.
fine.
Okay. Oh, leave. What is your target? What was your target pre-operatively the patient should have? And what about the other eye DVD, which will manifest after doing this?
Because
Where
I
we
have
have done
seen,
both the eyes?
Doctor, I have seen the photograph in which I think there is an inferior oblique overaction rather than DBT. Do you know the difference between these two?
Yes, sir.
So
Sir,
see the photographs, the 9-gauge
I
photographs.
did not see that.
ये देखो वो देखो जा रही है inferior oblique ऊपर ये जा रही है ना. So this is an inferior oblique overaction rather than DBT. Pandey must have seen, but I don't know.
sir, in
anyway.
inferior oblique, we get a V pattern as well. And
When you are seeing on the lateral gaze,
Obviously.
है ना, adduction position में where the right eye is there, just see that picture. When you are seeing in left gaze, where is the position of the right eye?
it is going
Okay.
up.
Okay, that is the point.
Yes,
Sir
ma'am.
explained. Now coming to the point which you have told us, that is the DVD. What if you do for a DVD for one eye? What happens to the other eye next? First post-op day.
Hyper.
A DVD is a unilateral entity or a bilateral entity?
Ma'am, usually it is bilateral.
Yeah.
But rarely it is unilateral. In our case, it was unilateral. And post-operatively, we found very minimal residual.
Can you give me the post-op pictures?
Yes, ma'am. After 6 weeks, we got this. And there was no
In
change
the
in
up gaze we can eliminate because reading position is more important. But you can see the difference in the up gaze, which I can see in this. And what about in the down gaze? Actually, when you, this is the way we depict the pictures, sir. But what I have seen, the mistake with this picture is you don't know the position of the chin of the patient. We depict all, I'm just communicating with sir. This is the way we all strabismologists depict 9 gazes. But in this picture, we cannot comment on the position of the chin of the patient. If it is like this also, and he's seeing like this, we don't know the position of the chin. So it alters everything.
Anyway, but good presentation. DBT can be committant, can be non-committant also, right?
Yes,
Both
sir.
the ways.
Yes, sir.
So bilateral can be unilateral, no doubt.
Yes, sir.
But anyway, the clarity must be there in your mind also while you are presenting the case.
Yes,
right?
sir.
Thank you.
Thank you, sir.
So, should I go for the next? Now the next is Dr. Naina G. I don't know. Naina G. Okay. She is going to present the acquired Brown syndrome, a rare case series.
A very good afternoon.
Good afternoon.
A very good afternoon to one and all. I'll be presenting a series of acquired Brown syndrome, which is a rare case series. So, as we all know, Brown syndrome is a rare ocular motility disorder characterized by limitation of elevation in adduction. Usually, it presents as a congenital entity, but can be acquired also. That may be caused by trauma, surgery, neoplasms, or any inflammatory diseases or infections. And acquired cases are rare, especially in the pediatric age group. And we present a series of 4 cases of acquired Brown syndrome with the varied presentations. So first one was a 3-year-old male child presented with complaints of acute onset of difficulty in the elevation of right eye. So there was a history of recurrent short episodes of restriction of elevation and elevation in adduction for the past few days associated with an abnormal head posture. The child was complaining of hearing a click before the occurrence of each episode, and there was a spontaneous recovery after a few minutes. So coming to the history, there was a history of similar episodes at the age of 2 years, and he was diagnosed as a case of acquired Brown syndrome during that time. A detailed lab workup and inflammatory workup and myasthenia workup and an MRI was done at that time, and all the reports were normal. He was started on steroids and pyridostigmine at that time by the neurologist, and the child improved after 2 weeks. So at that time, he was diagnosed as an acquired idiopathic Brown syndrome, according to the records. So after 6 months, again a similar episode was noted. So the diagnosis became recurrent idiopathic acquired Brown syndrome, and now it became intermittent. So examination showed a chinna posture with a head tilt, and there was right hypotropia. And FDT was done, and it was positive for elevation in adduction. So all the blood routine and the ESR and the other inflammatory workup was within normal limit. MRI brain and orbit was done and was normal. Test for myasthenia was negative. RA factor was negative. And so a diagnosis of recurrent idiopathic intermittent Brown syndrome was made. So according to our knowledge, it was the first case of recurrent intermittent idiopathic acquired Brown syndrome in the literature. So he was given 1 course of steroids and is under follow-up, and now he is improving. And the second was a case of 4-year-old male child presented with complaints of abnormal head posture for past 1 year. There was no history of trauma, fever, headache, or other inflammatory signs. He was treated with 1 injection peritrochlear steroid 3 months back from elsewhere, and the symptoms were persisting. So ocular evaluation showed marked chin up posture with face turn, and elevation in adduction was restricted. Blood workup and MRI was normal. FDT was strongly positive for elevation in adduction, and we corrected it surgically as it was already 1 year, and superior oblique silicone band expander was done. Postoperatively, the head posture and the elevation in adduction improved. Third one was a 20-year-old female. She presented with complaints of acute onset of double vision on the next day following delivery. It was a normal vaginal delivery. No signs of eye pain, headache, or ocular trauma was there. Ocular examination showed mild chin up posture with mild face turn to right and left hypotropia. And the FDT was done, and it was positive for elevation in adduction. Blood investigations and imaging was normal. She was given 1 course of oral steroid, but it was not responding. So she was planned for peritrochlear steroid injection, but she was lost to follow-up. This was the first case of postpartum Brown syndrome in the literature, according to our knowledge. So last one was a 5-year-old female child presented with complaints of occasional squinting for past 1 month. There was no history of trauma or fever, no history of other rheumatological conditions. On ocular examination, there was restriction of elevation in adduction for few seconds, which improves by itself after few seconds. And mild conjunctival congestion and minimal pain on the elevation in adduction was noted, and mild tenderness was there in the trochlear area. Blood reports showed an elevated ESR. Rest of the blood tests were normal. MRI brain and orbit was normal. She was treated with oral prednisolone, and the symptoms improved over a week. So to conclude, acquired Brown syndrome is rare and the presentations are variable, and the treatment should be individualized for each of the case. Inflammatory markers and imaging should be done in all cases of acquired Brown syndrome. Thank you.
But I think we agree that wonderful cases,
Sir.
if it be correct.
Sir.
I know that, have you done any ultrasound during the normal period?
B scan we have done, sir. In between the episodes, especially for the intermittent cases, we have done the B scan, but there was no other findings, sir.
How can you explain then the intermittent stage?
Sir, only
and what may be the region?
In the literature, I could find
Now,
only.
forget the literature. What do you think in your cases? Why this is intermittent? Because once you say that the Brown syndrome is there,
Sir.
so how can you say that this is intermittently? Sometimes it's normal, sometimes it's
But I have the video
like
also,
the intermittent
sir, but
exotropia, I
it
don't
was
know.
coming like that. And in the first case, the child is even feeling that click every time he's
the
getting that
fibrosis
episodes.
cannot go even in between, whatever may be the
But maybe some
regions.
inflammatory, it may
The
be
region
due
may
to
be-
the inflammation.
If
sir.
it may be the inflammation, that must be You should know that what kind of inflammation is there,
Yes,
and
sir.
does it respond to the steroids or any
Yes, sir.
inflammatory
Except one case, all the other cases were responding to steroids, sir.
steroids?
Yes, sir.
What dosage you were giving?
Sir,
What dosage you were giving?
1 mg per kg, madam.
Okay.
In tapering doses we gave.
Okay, and did you evaluate the sinuses also?
Yes, sir.
And so how was it?
MRI first we have done, so any signs of sinusitis we could get in that also.
Yeah. So in such cases with Browns, you should treat the patient for sinus also.
Yes,
Because
sir.
sometimes frontal sinusitis
Yes, sir.
may lead to acquired Browns. So this should
Yes,
be
sir.
taken care.
Ethmoid and frontal sinusitis can cause acquired Brown syndrome.
I think she has a very nice presentation and very good, nicely conveyed everything.
Thank you, madam.
Have you done any surgery also? No.
Yes, sir.
You have done
One
this-
case, silicone band expander we have done.
Yes, they put. In the second
silicone
case, they put.
expander. But all the 3 cases were intermittent type of, as you are saying. Sometimes they are normal.
No, sir,
sometimes
that one case was constant, one was intermittent, and one was only for few seconds it was staying, and beautifully it comes back, sir. So,
Okay, so the one who was constant, you have done the.
yes, sir, for that we have done the surgery, sir.
Okay.
Thank you, sir.
What do you think?
Nice presentation. Nice connection.
I don't know.
But I have also seen like cases which
Well, Leela had never talked about all these things. And it's hard to believe in inflammation may give rise sometimes.
seen it. Like, sorry, I'll just switch off.
Okay, the last one, Dr. Sarita. Sorry, Ravindran.
So good afternoon. My topic of study was health-related quality of life in adult patients with strabismus. While a lot of importance is being given to the clinical and surgical aspects of strabismus, the psychosocial and functional aspects are seldom emphasized. So health-related quality of life provides a comprehensive assessment of the physical and mental impact of the disease on the patient. AIOS20 is such a validated questionnaire which provides insight regarding the same. So the aim of my study was to evaluate health-related quality of life in people with strabismus using the AIOS20 questionnaire and to determine the association between HRQOL and the type of strabismus. So it was a single-center study comprising of 83 patients and included adults more than 18 years. We excluded patients with history of previous Squint surgery and history of psychiatric or debilitating illness. All patients underwent a comprehensive ophthalmological examination, a Squint evaluation, after which the AIOS20 questionnaire was administered. The questionnaire has 20 questions, 10 in each of the subscales, psychosocial and functional, and the scoring was based on a 5-point Likert system, where never stood for 100 and always stood for 0. The psychosocial subscale had questions like if the patient feels inferior, uncomfortable regarding the eye status, and the functional subscale included questions regarding depth perception, concentration while reading, etc. So the AIOS20 scores were the statistical mean of the 20 questions, where 0 stood for the worst quality of life and 100 for the best quality of life. The mean AIOS20 score was 51, which was on the lower side. There was no association between age and AIOS20 scores or gender, type of strabismus, or degree of strabismus. Poor presenting visual acuity in the better eye was associated with significantly lower scores in our study. So the median AIOS20 score in a non-strabismic individual is 85 to 100 according to SR Hat, who was the one who derived the questionnaire. So the findings of our study concurred with that of SR Hat, where quality of life was found to be poor, affecting both psychosocial and functional subscales. Other authors have found that patients with strabismus, adults with strabismus, reported higher levels of social anxiety when compared with age and gender matched controls. Some other studies found that they exhibit lower levels of perceived happiness and heightened rates of depression to their non-strabismic counterparts. Our analysis revealed that the mean AIOS20 and subscale scores were low irrespective of gender, and the difference was not statistically significant. While other studies showed lower scores among females. This is probably because of the local in the localites considered squint in females to be a sign of good luck. The esotropes in our study seem to have markedly lower scores than exotropes, p is equal to 0.056. Although a trend was seen, this study was not powered enough to explore the effect of differences among subgroups. And though our study had no significance, found no significant association between degree of strabismus and HRQOL, some other studies have found that deviation of more than 10 PD was associated with a higher psychological impact. Poor presenting visual acuity was associated with lower psychosocial scores in the better eye, and a lot of other studies concurred with the same findings. So the observations in this study were that patients did not seek treatment, both medical or surgical, due to poor awareness as well as local beliefs. We consider the possibility that visual acuity could be a confounder, and we analyzed the associations between age, gender, type, and degree of deviation with the AIOS20 and the subscale scores. The results were still statistically insignificant. So to conclude, our study has found that health-related quality of life was reduced in all patients with strabismus, irrespective of age, gender, onset, type of strabismus, and degree of deviation. Irrespective of refractive status, poor vision in the better eye was associated with lower score and significantly affected the quality of life of adults with strabismus. Thank you.
Thank you. Any question from the audience related to everybody? Thank you. Thank you.
Thank you.
बस आप देर में आए ना, 4 भाग गए. All the presenters are requested to come here. Please take the photograph. So, are you there?